tremendous pleasure today to have Dr. Jim Leyden, who's well known to us as someone who's spent a lot of time in his career on acne and specifically a lot of work with P.Acnes. So we'd like to welcome you today, Jim, to Clinical Audiopearl for the American Acne and Rosacea Society. One of the questions I have really starting off, because a lot of the emphasis has been on Propionibacterium acnes, is what evidence do we actually have? And this, I know this may sound somewhat elementary, but I think it's really important. What evidence do we have that P.Acnes plays a role in the pathogenesis of acne? And if it does, to what extent is it actually contributing to the pathogenesis of acne compared to maybe some of the other mechanisms that people have brought forward?
The areas of abnormality in the skin of these teenagers with acne is obviously enlarged sebaceous glands and increased production of sebum, and that's been identified as the first abnormality that can be seen in the skin of children who go on to develop acne in prospective studies. Subsequently, two other things happen. The accumulation of abnormally desquamated follicular corneocytes, which occurs first at a microscopic level, first described by Strauss and Kligman in their landmark histology of acne many, many years ago, and now frequently referred to as the microcomedo or the microcomedone. And subsequently, if there's enough accumulation of that material, you can see it clinically as a non-inflammatory closed comedone whitehead or open comedone blackhead. The other thing that happens is that after there's increased sebum, the first thing that's seen clinically in acne in children is the presence of comedones. And many years ago, Bob Lafker and I studied those both at the ultrastructural level as well as microbiologically. And at that stage, there is no P.Acnes colonization within follicles. This is by extracting comedones, homogenizing them, and growing them on appropriate media. If you do that to teenagers and adults, you get millions of P.Acnes per.
But in that stage where there's not any P.Acnes, you actually have a visible, let's say, closed comedone present?
You have an open comedones. We expressed open comedones. They're much easier to get your hands on. And there's no P.Acnes at that stage. And at that stage, the acne is a non-inflammatory acne, as Ann Lucky showed, I think, fairly convincingly in a fairly large longitudinal prospective study that she was able to do some years ago. Subsequently, when P.Acnes colonization takes place, that's when inflammation develops. So that was kind of the early clue, if you will, that this organism, which you can find on the skin of adults without disease, may in some way be playing a role. And the thinking was that it might well be something akin to what you see in periodontal disease, where you have an environment that's fundamentally different that allows organisms that are normally there to proliferate and through a variety of mechanisms induce inflammation and damage. It became clear, probably, I guess we're talking now the late 60s, early 70s, that this organism, we published a paper in, I think it was 1970, looking at the skin of children with and without acne. And we clearly showed that there was a huge, orders of magnitude differences. The occasional children with some P.Acnes, but it probably was mostly transient contamination, whereas you could easily find, 10 to the 5, 10 to the 6 per square centimeter P.Acnes in kids with acne. Well, shortly after that, a classic study was done by Strauss and Poche, published in the New England Journal along with Ruth Frankel. And dermatologists had discovered empirically that tetracycline and erythromycin, but particularly tetracycline hydrochloride, was very useful in treating acne, particularly for suppressing the inflammatory lesion that these patients get. And they showed that the improvement in acne was associated with a decrease in free fatty acids on the surface of the skin. Subsequently, we showed that P.Acnes was responsible for the free fatty acids. So now we're about 1972 or so, and the way acne was viewed was, for some reason, there was increased sebum. Subsequently to that, there was this overgrowth of P.Acnes. P.Acnes hydrolysis of sebaceous gland triglycerides led to this marked increase in fatty acids, which was responsible for the inflammation of acne, and antibiotic like tetracycline reduced P.Acnes and reduced free fatty acids, and that was why acne got better. It added some rationale to what dermatologists had discovered empirically, because when antibiotics first became available in the late 50s, early 60s, they just started using it in everything.
You found P.Acnes, but how did you exclude other strains of propionic bacteria, or maybe some of the other organisms that are present on the skin?
Yeah, that's a good question.
Yeah, because a lot of people will say, well, I think Malacea plays a role. I think these other strains of P.Acnes play a role, and other strains of propionic bacteria. I mean, not other than P.Acnes. How do you exclude some of these other?
Well, first of all, there are other species of propionic bacterium, but Propionibacterium acnes is like 99.9% of what's found on facial skin. So the other strains just aren't there. So that part's easy. The question was, what about other organisms on the surface, like coagulase negative cocci, and what about the yeast, formerly known as Pityrosporum, now known as Malacea, this, that, and the other thing? And that was a question that Dick Marples and I addressed around the same time. And what we did was take a series of antibiotics and treat volunteers with them and measure what happens to the surface flora as well as what happens to the subsurface sebaceous follicle flora, P.Acnes. In those days, unlike today, the surface flora was very, very sensitive to a wide range of antibiotics. So we used penicillin, ampicillin, tetracycline, erythromycin, and maybe we used a sulfa, I can't remember right now. And what we found, interestingly enough, is that, talking about the surface flora, is that coagulase negative cocci, micrococci, lipophilic and non-lipophilic dipteroids initially would be suppressed by a wide range of antibiotics, including penicillin, including tetracycline, ampicillin, erythromycin. But very strikingly, by 6 weeks, that surface coagulase negative cocci and dipteroid flora had become, the numbers had come back to pre-treatment levels, because the occasional less sensitive, or if you will, resistant strains had an ecological advantage, and they would begin to proliferate in the absence of the other sensitive strains. So, you could say, well, could those organisms be playing a role? Well, antibiotic therapy then would work for about 6 weeks, because
right.
the surface flora is suppressed and then it comes back to pre-treatment levels. There's no way of quantitatively culturing the yeast off of skin. There's been many attempts over the years, various techniques using olive oil overlays and things like that, but it just really has never been achieved. So you have to resort to removing things from the surface and basically using an ancient technique of dilutions and counting with a basically hematocytometer type of device. And using that, which is a much cruder technique, there's no change in the yeast with tetracycline or minocycline, doxycycline, erythromycin. So those organisms anatomically are very near the top of the sebaceous duct, which is actually shaped a little bit like a chalice. It comes up as in a normal skin, in a normal situation, it comes up as a thin canal, and at the top there's a little bowl-like dilatation at the acroinfundibular area, and that's where Pityrosporum or Malacea is. So it's kind of geographically not where the action takes place in terms of the inflammation of acne at the histologic level. The organism is not, those yeast are not suppressed or influenced in any way by antibiotics. So we concluded that the yeast probably contributed a little bit to the free fatty acid concentration on the surface, but because it wasn't suppressed by effective therapy and it was geographically sort of out of play, that wasn't involved, and that the cocci and diphtheroids were not involved in pathophysiology because, again, they were even more geographically out of the ballpark, and they were initially suppressed and then returned to pretreatment levels while P.Acnes continued to go down and patients got better. So those were the kinds of pieces of evidence that
kind of put the spotlight on P.Acnes versus those other organisms at the end of all those studies. Taking it one step further, so you have patients, they have acne, you're seeing a proliferation of P.Acnes organisms. I guess I have a
in the microcomedone. I think part of that, Jim, is that the organism P.Acnes prefers a reduced environment. It's not a strict anaerobe, like Clostridia, for example. So it can tolerate some oxygen, but the less oxygen, the better.
Right.
And there were some attempts at measuring what was going on there done by Keith Holland and Bill Cunliffe and that group back in the early 70s, and the environment was more reduced in the presence of comedogenicis. So that probably, along with sebum, since the organism can utilize triglycerides as a growth substrate, the presence of increased sebum and the presence of decreased oxygen is the environment that allows that organism to proliferate.
A question I have sort of in two parts is there a critical level of proliferation of P.Acnes that you need to get to? Like below that level, you're not going to see development of acneiform lesions. Above, you will. The amount of proliferation of P.Acnes does not necessarily correlate with the severity of acne across the board. In other words, if you took patients with much more severe acne, they don't necessarily have the highest proliferation levels.
Yeah, that was one of the things we very early became aware of, and I think the answer to that, this is obviously mostly hypothesis because nobody's done the longitudinal study to test what I'm about to say. But I think my way of thinking is that the stimulus to inflammation in acne in those with mild to moderate to severe inflammation is basically pretty much the same. There's been attempts to see if there were differences, either in terms of something about the organism, and they have not really panned out. And so I've thought of it as the difference in response, and that difference can change over time. And I think that's something that we do see fairly commonly clinically. In other words, you start treating a patient when he or she is whatever, 13, 14. They're well controlled, and then somewhere along the line, all of a sudden that acne and the inflammatory response in the patient becomes a different kind of animal and becomes much more intense.
In clinical practice, we blame that on the patient not adhering to the treatment.
I don't believe that.
Yeah, I don't either.
I don't believe it at all. I think there are plenty of patients who are adhering very nicely and doing well, and then all of a sudden it becomes a much more different kind of inflammatory response.
But anyway, going one step further, before we get into the whole issue of antibiotics that in the past just brought P.Acnes down very dramatically to not so much anymore, can you just explain, so when readers are reading studies, the whole concept of the log reductions and what those actually mean? Because sometimes people report you're getting 80% reduction, 90% reduction, 99% reduction in P.Acnes in a certain study. as compared to reporting?
Well,
log
in my
reduction?
yeah, I think that the arithmetic numbers and 85% reduction, 90% reduction are much more comfortable for non-microbiologists. Microbiologically speaking, anything less than 90% reduction, it means probably nothing much happened. Now, you know, $1 million sounds like a whole lot more than 100,000, but 900,000 organisms and 200,000 organisms are really basically not different enough for one to be comfortably believing that difference. So I understand why companies change things into percent reduction, but basically for meaningful reduction, 90% reduction should be the minimum. Then the next level is 99%, and then it's 99.9, and then 99.99. In other words, organisms, because of their generation time, you have to think of it in log terms, in terms of meaningful reductions. So going from a log of 6, which is 1 million, down to a log of 5, which is 100,000, that's a meaningful reduction. Going from 6 to 5.4 is less meaningful and could just as easily next time be it went from 6 to 6.2.
Okay. Taking it one step further, let's say we had a patient and we were testing 2 drugs in a split face, you know, that you were controlling what you were applying on one side versus the other, and they have, you know, the same level of acne. They have quite a bit of inflammatory and some comedonal acne on both sides of their face. One side you're testing drug A, one side you're testing drug B. Let's say on side A you got a much greater reduction in the P.Acnes than you did on side B. How much correlation is there between clinical improvement?
So you really want to know what magnitude of difference really correlates with a crisp clinical difference. We don't have the answer to that, but we have lots of evidence that reducing P.Acnes is associated with clinical improvement.
But you would be comparing apples and oranges between 2 different studies that are reported.
Yeah, you'd really like to see. You could see it in parallel groups, but you'd also like to see it when you can with topicals. You could do it within the same person.
You know, taking it one step further to the treatment room now. So, you know, there's a lot of discussion about P.Acnes resistance, and I want to stop there because I know this is one of the things I heard you say that I think makes a lot of sense. We have to be careful about that term resistance. It's more decreased sensitivity to the antibiotics. Can you explain what that is?
This is the way I like to say it. First of all, the sensitivity of P.Acnes to antibiotics has clearly changed dramatically. 20, 30 years ago, the organism was exquisitely sensitive to a wide range of antibiotics with the exception of aminoglycosides and more recently mupirocin. So it was, you know, the MICs were in the 0.01 range. We searched and searched and searched, and we could not find a strain that had a different MIC. Something happened in the early 80s, which incidentally was right around the time dermatologists, at least in the United States, started using extemporaneous formulations of clindamycin and erythromycin. Shortly thereafter, there were FDA approved, and all kinds of things were being formulated at this, that, and the other concentration, and dermatologists were very happy with, you know, they were clearly, you know, it was not a fad, it was something that kept growing, and then FDA-approved versions became available. So it was right around that time in the early 80s that we started to see some strains that had different MICs, and then we collected a small group who had large numbers of P.Acnes that were far different, particularly to erythromycin, and also we had some that were different MICs to tetracycline. And we cultured them and then treated them with antibiotics to which their organism was sensitive, and their P.Acnes counts went down, and they went from not being responsive to being responsive. So we reported that in the early, like 83 or something like that. And then by the end of the decade, it was hard to find a patient that did not have strains that were far less sensitive to erythromycin, and it was increasingly easy to find strains that were less sensitive to the tetracycline family. And that trend continued, and by the year 2000, no patient with acne had strains that were sensitive to erythromycin. All patients who had been around for a while had mixed populations. They had both sensitive and insensitive strains.
Because in the past, there was a thought that if you had patients on antibiotics and you're selecting out these less sensitive strains, but then you stop the antibiotics, they revert back to the strains that are more sensitive.
It's not always the case. We had one study that went, I think, 12 weeks, and another went 20 weeks, and the changes that occurred in those who were on for 20 weeks did not revert. They reverted a little bit, but they did not go back to the pre-treatment. The shorter exposure had a much greater percentage of patients went back to their pre-antibiotic pressure levels. Based on that and some stuff that Anne's group had done, Anne has been responsible, I think, for changing the pattern, the practice of using antibiotics, at least in Europe. Many parts of Europe, they use antibiotics for 3 months and stop. And if the patient is clear and then acne comes back, which happens a lot, then they put them on isotretinoin. And if the patient isn't clear, they don't start looking for other antibiotics. They just move right on. In most parts of Europe, do not have patients on antibiotics for long periods of time.
A lot of the data we have when we look at individual antibiotics, really, on P.Acnes reduction, some of the data is older.
When a dermatologist is sitting there looking at a patient, especially a patient who's been treated for some time, but even relatively naive to treatment patients, they're going to have mixed populations of P.Acnes. They're going to have large numbers. Almost all the patients are going to have, most of their flora is going to be very, very insensitive to erythromycin. But to the tetracycline family, there's going to be mixed populations. They're going to have strains that are very sensitive, strains that are clearly different. You can have two patients that come in that look the same, and one could have most of their flora be very insensitive, let's say, to doxycycline, and the other one has 90% of the flora sensitive. They look the same. You put one on, and the one patient comes back 2 months later, and is thrilled. The other patient comes back and is maybe a little bit better, but not much.
Now, I know that we see a greater prevalence now than we have in the past of less sensitive P.Acnes strains to tetracycline. What about doxycycline, minocycline, and even trimethoprim?
Well, there haven't been any recent surveys. What we really need, and we don't have, is we don't have crisp breakpoints. When the word resistance is used in a clinical setting, it means that the organism, E. coli in the bladder, or Staph aureus in your blood, or something in your spinal fluid, it means that the concentration of antibiotic needed to inhibit the growth of that organism cannot be achieved in the compartment. So it's clinical breakpoints have been established. So when you get a culture and you get back a report resistance, that means if you use this antibiotic, you can't achieve a concentration in the compartment you're trying to deliver enough antibiotic to assist this patient in killing the organism. We don't have that because we don't know what concentration can be achieved in individual sebaceous follicles. That has eluded detection, although there have been no attempts to do it in the last 15 years.
And that could really, be important in terms of the differences between if you have a given antibiotic that can be given orally or topically. Maybe orally it's not going to achieve the levels that you would want.
Yeah, it would be if we knew what could be achieved by a topical and or oral agents, then we could sort out patients a lot easier than has had to been done to date. What has been done is taking collections of patients and looking at their P.Acnes and looking at their response to antibiotics to which they're more or less sensitive, and the gist of, and they're hard studies to do, believe me. Those studies clearly show that it can matter. The problem is it's not easy for someone in a clinical setting to get any sense of how important in a given patient it may or may not be. In the case of clindamycin, which is related to the macrolides, the erythromycin, azithromycin, etc., the spread of the MICs in these erythromycin, high MIC strains of P.Acnes is very variable. There are those that are very high, there's an intermediate group, and then there are those that are relatively low, much higher than they used to be years ago, but they can range from 8 to micrograms per ml, which is the most sensitive, to way in excess of 1024 micrograms per ml. So what I did was get a couple of collections of patients in whom they had a range of MICs to clindamycin, and then treated them with, in one study, with 1% clindamycin twice a day, again in a laboratory setting, and then another group in a half-phase study with clindamycin on one side and tretinoin and clindamycin on the other side. And just looking at the clindamycin response or lack of microbiologic response, what we found was those who had populations of P.Acnes with 256 micrograms per ml or less as their MIC, that we got an antibiotic response very comparable to what we saw before all this antibiotic sensitivity change took place.
You're talking about a clinical response?
Just purely microbiologic. So in those with 512 and above, we got practically no response. So it looks like at least we have a microbiologic breakpoint.
Right, and there are differences, some differences in the resistance genes between erythromycin and clindamycin, I believe. That some
yeah,
of
that's
them,
true.
Yeah,
but
but
that allows us to have a nice range of sensitivity. So I thought that might be a good place to start, because 8's very different than 1024. You can look microbiologically. Where do you get an antibiotic effect, and where does that antibiotic effect wear off? And it's pretty crisp that the 256 and below you get a good effect. 512 and above, which is one dilution beyond 256, it falls off. So
one of the things I wanted to ask you, because sometimes we can jump to conclusions based on what we see in clinical studies, and in going back and looking at everything that I could find with topical clindamycin, where it's been evaluated as monotherapy to see what its actual efficacy in clinical lesion reduction is going to be. Even many of the recent studies that we've had, where we've had large monotherapy arms in the studies to evaluate combination products.
Plenty of patients still do well.
Right, the patients still do well, but they've been washed out. So, in that period of washout, at least for a period of a month usually with a topical, they've not been exposed to any drug, so they could be repopulating differently.
That's one possibility. The other possibility that's more attractive to me is that when you have, like in the Sienna trials and the other things with clindamycin in it, and you have an arm that just got clindamycin alone, the way you see the data, it talks about the mean effect. It doesn't tell you how many people didn't get better. You got to see what the spread of response was clinically. That you say there's a mean reduction in a group of 200 patients of X. Well, there's a spread around that. And well, how about the ones who had no response or practically no response. What was their MIC versus those who had a good response? You have the issue of adherence, but assuming you take care of that, it would be very, very instructive to be able to see if those who didn't do well had large numbers of P.Acnes that were much more insensitive than those who did get better. I've done a grand total of 40 patients now with clindamycin of different MICs, and at least microbiologically, there's a very crisp difference. Now, I'm not so sure that clindamycin or even tetracycline or doxycycline or minocycline has any effect other than microbiologic effects in the case of acne. I'm willing to believe they might, because they certainly do have lots of effects in systems that
the macrolides do, obviously tetracyclines,
they have effects in these systems, and that mean that that's a possible thing that could be happening in acne. But the only way you can do that is to treat patients with the disease and show an improvement in the absence of a microbiologic effect.
Moving on to looking at doxycycline and minocycline, I know you've done some studies. One was with a benzoyl peroxide cleanser, where you went out and found patients that already had pre-existent strains that were less sensitive or resistant, whatever, to erythromycin, tetracycline, doxycycline, and minocycline. I know erythromycin, it was easy for you to find those patients, and probably tetracycline. And you broke them down into high and low level resistances. You still found people that qualified to be, quote, resistant to doxycycline and minocycline, maybe not as easy. Is it easier now to find these people? These patients have strains resistant to antibiotics that in the past we thought, hey, no problem, we're not going to see resistance with such and such an antibiotic.
Unfortunately, that's not the case anymore. The one antibiotic that seems to have not changed too much is trimethoprim sulfamethoxazole, but people shy away from that for the obvious.
And it's not being used as I would imagine that seeing these decreased sensitivities, and I think looking at studies from around the world with antibiotics in general, has to do with how much antibiotics actually being used in that geographic location.
Well,
it can reverse over time.
Yeah, that's almost for sure the case. And in the study that Leeds Group, where we got strains from around the world to look to see whether the mutations identified in our population and their population were similar to other parts of the world, including Australia and various parts of Europe, etc. There were some differences, and those differences seemed to correlate with differences in
use in that area.
Yeah.
That's why I'm saying about trimethoprim sulfamethoxazole. I don't think the chronic use in acne is as prevalent as.
There was a time when it was used a lot, and then a lot of things changed in the early '80s when Accutane became available. When the drug was first approved, I think I put 500 patients on it in the first month. That I just had sort of stacked in the bullpen, waiting to be treated differently than the way they had. We don't have any recent surveys, and I think that's a very important point. But when it's been done in the past, and we don't have enough to say, although I think it's still true, the organism is most sensitive to minocycline of the tetracycline families. And that clearly is the most lipophilic of the tetracyclines, and based on the past comparative in vivo reduction of P.Acnes over time, was much more effective than doxycycline.
And it lasts longer after you stop the drug.
Which we argued probably represents slower clearance out of this lipid-enriched tissue. So that's probably still true, but it hasn't been done.
Some people, occasionally you'll see a poster at the academy where somebody's studying a drug, and they have 2 or 3 sentences there about P.Acnes reduction, and you're reading about how they did it. They had some P.Acnes in a petri dish, and they throw some stuff on it, and it goes away. And I get concerned about some of the methodologies that are used.
Lots of things work in vitro. I mean, I have I get the chance every year now for the last 40 years or so to look at anywhere between 5 and 10 compounds that people have identified because of the in vitro activity, and they're looking to possibly develop it. And 99 out of 100 fail because in vivo they can't get into the target area, the sebaceous follicle. So when you see studies like for the best example I can tell you is blue light. Blue light will kill P.Acnes in vitro because of interaction with copoporphyrin, but it doesn't kill P.Acnes in vivo. If it happens, it's not measurable as far as I'm concerned. As far as culturing the skin of patients, the techniques are pretty straightforward, and over the years, various people have wanted to do experiments. Diane Tibethod's group wanted to do some experiments a year or so ago, so they came down and spent the morning, and then they went home, and they had no trouble. So it can be. It's not that hard to do, quite frankly. It's just something that people have, not found an interest in for one reason or another, at least in this country.
Before going on to how we may be able to suggest to clinicians dealing with a less sensitive response to antibiotics in actually treating patients, with the topical antibiotics, I know there was some work done years ago where you would apply a topical antibiotic. I think it was done with erythromycin, and you could see in other remote areas where it hadn't been applied, overgrowth of staphylococci, including Staph aureus, like in the nares or another area of the skin. Can you address what the significance of that might be now that Staph aureus is getting front page news all the time, or how that may influence community-acquired MRSA? I know this is a totally opening a can of worms, and we don't have time to go through all of that, but at least in terms of what topical antibiotic application for acne might do.
The studies that were done where there was a big interest by a couple of companies, very large companies, in going to OTC with erythromycin. So the FDA was very interested and concerned that there might be some, as we like to say, ecological mischief, that it wouldn't be so obvious. The most obvious is the relevance to P.Acnes and efficacy that we've been talking about. But this was before P.Acnes was universally so insensitive to erythromycin. So these studies were funded by industry. They were great studies, and we published them in two huge studies, one that we did in Philadelphia and Boston. And, they were big studies that we were able to publish in some pretty good microbiology journals because they had a lot of stuff of interest to those of us interested in this stuff, which is not dermatologists. There's no reason why dermatologists should be really interested in this except for overall, ecological mischief is something we all want to try to avoid being part of. And it's clear that treating the face influences the anterior nares. And in both studies, the use of a topical antibiotic alone, like erythromycin, was associated with an increased carriage of Staph aureus, particularly in the nose. And treating the face influenced in those days, when we did these studies, the surface flora wasn't as uniformly insensitive or resistant. The coagulase cocci were mixed in those days, so we could look at quantitative changes. Now, that doesn't matter because they're all insensitive or resistant, but somehow influencing the ecology of the nose so that Staph aureus could find its way in there was clearly seen in both studies, and it's not understood what the mechanism is, but the fact is that it can occur.
It occurs during isotretinoin treatment too, also.
Oh yeah, we showed that. Yeah, that clearly happens during isotretinoin. When you have a patient whose nose is irritated, there's a lot of Staph aureus in there. And in fact, Bill James and I reported years ago some of those patients late in the course of treatment can suddenly look like their acne is worsening, and what they're really getting are Staph aureus lesions as a result of the organism spilling out of the nose onto the face or into the
So
hand.
not necessarily gram-negatives overgrowing.
Oh, no, gram-negatives die with isotretinoin.
Oh, yeah. But when you see worsening, you could be staph then.
Right, but on Accutane or isotretinoin, it's Staph aureus. So that can occur. We never did a big enough series to publish or anything, but in the case of a benzoyl peroxide antibiotic like clindamycin, benzoyl peroxide. Anyway, somebody who doesn't sell antibiotics was interested in whether or not benzoyl peroxide clindamycin might have the same problem erythromycin has, and what we actually found was that somehow that benzoyl peroxide must also get in the nose because it actually we did two groups. We did those with Staph aureus in their nose to see if it increased, and we did those without Staph aureus to see if they became carriers. And what we found is that there was no increase in carriage rate, and those who already had Staph aureus, it went down. So just like benzoyl peroxide can help suppress resistant P.Acnes from either developing or proliferating when they're already present, it appears that benzoyl peroxide can also positively influence the nose so it doesn't become.
With Staphylococcus aureus, I think that's an important point about benzoyl peroxide. Somebody's applying erythromycin to their face, and over time the sensitive strains are obviously going down, and there are some Staph aureus strains that are less sensitive that they proliferate. I mean, people do what they do, and they put their fingers in their nose or whatever, and that, you don't necessarily have to be applying the benzoyl peroxide in your nose for it to not get in the nose. Just preventing the strains from becoming less sensitive on the face would prevent them from getting.
Yeah, obviously some benzoyl peroxide gets in the nose, either from the hand or from migration across the skin or.
That's an important point for, I think, benzoyl peroxide is. It's not only targeting P.Acnes, it has a lot of antimicrobial.
Yeah, as I say, we never published that.
I think that's very clinically relevant information. So now to the clinicians that have been hanging in there, sorting through all this. We have patients in practice. We're in a different time and place than we were 10, 20 years ago, 30 years ago, and they're treating patients. What can they do to try to reduce the problems that we have with strains that are less sensitive to antibiotics, both when patients are coming in with those pre-existent, which they obviously can't separate out, they can't culture for, but now they have patients on oral antibiotic therapy or topical antibiotic therapy or both. What would you recommend that they really pay attention to from the outset when they're initiating treatment?
I think if you're going to be in a situation where a patient is going to be on antibiotics, if you're going to do that, then I think you need to be using some form of benzoyl peroxide as part of what you're doing, either as benzoyl peroxide wash, which for the face is fine. Interestingly, they don't work so well on the trunk.
Yeah, we're going to do a separate discussion on truncal acne. That's one of the reasons why I wanted to address that. So, if you're using a leave-on benzoyl peroxide formulation, obviously it may be quicker in reducing the P.Acnes, but if the patient can't do that or you're dealing with issues of compliance steps, a good benzoyl peroxide cleanser can help reduce the resistant P.Acnes and maybe some of the other organisms we talked about. Right?
For sure. Yeah, I mean, that's what benzoyl peroxide is the answer.
Okay. Another question I had for you is, a lot of times you'll have patients come in, and occasionally you'll see people put little articles together of, collections of cases where they come in. I get them because they moved to Las Vegas, so they live there 6 months of the year, and they come in and they tell you, I'm doing well, I just need my prescription, and you see that they're on, for their acne, ampicillin, cephalexin, azithromycin, and they say this stuff works, and when I stop it, the acne comes back. I've been on it for a few years, not having any problems, and I use it in combination with whatever topical. What's your feeling on some of those alternative antibiotics?
Well, I would tell you that the penicillin and its derivatives do not reduce P.Acnes, but ampicillin is very good for certain strains of gram-negative organisms. So a patient who's clear, you don't know what they look like when they're not clear.
Right.
They may not be having acne vulgaris. They may be having gram-negative folliculitis. Azithromycin is an interesting molecule. It's a macrolide, and the sensitivity in vitro of P.Acnes is absolutely the same as erythromycin. Now, the interesting thing about azithromycin is it is very, very lipophilic. So it is conceivable that azithromycin may be capable of achieving concentrations in the follicle far greater than erythromycin, and that the current MICs can be exceeded by that drug. I don't know.
It's a very high tissue level drug with very low serum levels. That's why people don't use it for any type of prophylaxis where you need a high serum level. So it does get very high tissue levels.
Yeah, and it is very, very lipophilic, so it may be able to achieve a level in sebaceous follicles that exceeds the current MIC.
Before summing up with for the clinicians, I just want to get your thoughts. There's a lot of talk about post-inflammatory hyperpigmentation, but we see a lot of very fair-skinned individuals, like someone with Jim Leyden type skin, who comes in and then their acne lesions are flattening out. But their erythematous macules, which are the flattened, resolved, or at least palpably resolved acne lesions, that erythema sometimes persists for months, as opposed to treating other diseases that have a lot of inflammation on the skin, atopic derm, psoriasis. They have some persistent erythema, but it doesn't last months after the disease clears. What's going on in acne?
We did a study back in the late 60s to see how long those things can last, and they can disappear in days or they can take months, and you can't tell by looking at one up front whether this one's going to last a long time or whether it's going to fade quickly. It's really interesting. So what could possibly explain fast-leaving and slow-leaving ones? Well, we know from Guy Webster's work when he got his Ph.D. that the organism P.Acnes, again, remember I mentioned earlier, it's a little bit similar in some respects to mycobacterial organisms, big, thick cell wall. It is not processed well by the body. In other words, it's a slowly broken down and gotten rid of by the host defense mechanisms, by macrophages, et cetera. So we hypothesize that these persistent lesions must have remnants of P.Acnes cell walls, et cetera, that are still capable of an ongoing inflammatory response, not of the intensity to produce a palpable raised pimple, if you will, but enough to have this flat erythematous macule. If you biopsy those ones that are persistent, there is an awful lot of inflammation there. It's not just
isn't it a lipopolysaccharide in that cell wall that triggers the toll-like receptor 2? So could that still be operative in a dead P.Acnes? Or?
Well, they're down in the dermis, so it's a question of where the toll receptors are, which are mainly an outpost sentinel early defense mechanism. They're up in the epithelium. But nonetheless, it's a persistent inflammation, so there obviously has to be a stimulus to it. The likely candidate is a remnant of P.Acnes cell wall and ongoing stimuli to inflammatory pathways in some areas, and in other areas the organism is cleared more rapidly. But
have you observed, in treating countless patients with acne, that there are any particular therapeutic agents that seem to get that to resolve? I know it's purely would be observational. That get the
no, we actually did. We did lots of
quicker?
studies on that. We did lots of studies on that years ago, and the only thing we ever found that helped at all were high-potency topical steroids, which are not a good idea because they are.
What if you did it for a week, though? What if you did it for a week? Would it, just a week or two? Because that's, people could live with that. Do you think that would make a difference?
It does make a difference. It's just difficult to get people to stop. if their acne is, I mean, it can be a trap.
Well, we've certainly gone over what we usually do, but this is at least to me tremendously fascinating. But now you have any final words on things that you suggest to clinicians not to do with antibiotics in practice to avoid the problems of resistance? I think one of them would be not to buy into using them as monotherapy.
Yeah, I think I think antibiotics should be used in combination with retinoids in the vast majority of patients, and I think benzoyl peroxide in one form or another should be added. The question is, do you have to do it every day? Can you do it every other day? Probably you can get away with not doing it every day. That's not been formally studied, but the evidence is pretty clear that benzoyl peroxide helps to minimize the adverse effect that antibiotic ecological pressures can have clinical outcome consequences.
Well, Jim, I really want to thank you for your time and your expertise and really all the work you've done over the years and sharing it. Tremendously valuable to the listeners.
Okay. Thanks, Jim.
This concludes part one of our discussion with Dr. Jim Leyden on Propionibacterium resistance in Acne vulgaris. And in part two, we're going to continue this very exciting discussion.